Hello and welcome to this lecture about special considerations in critical care. The objectives of this lecture are to describe the needs of the critically ill obstetric patient, the infant and child, and the older adult. And we'll discuss some anatomical differences of the infant and the adult. And we'll also discuss some common physiological changes of aging and identify common illnesses of the elderly which may lead to critical illness. So obstetric emergencies in ICU. Well, there's many reasons why a pregnant lady may be admitted to the intensive care unit, such as hypertensive disorders like preeclampsia, hemorrhage, this could be PPH, so postpartum, respiratory failure, sepsis and trauma. So it's important to know when we have obstetric emergencies in the intensive care unit, the choice of drugs may be limited, and that's due to some of them crossing the placental barrier. So chronic opioids should be avoided, and that's because it can lead to fetal withdrawal. And non-steroidal anti-inflammatories can lead to decreased renal blood flow. And if midazolam is given near the time of delivery, that can lead to neonatal depression, so we need to be very careful. But opioids and midazolam are used commonly in the ICU for sedation. So we need to nurse our obstetric patients on the left side, and that's to increase venous return from the inferior vena cava. And because of the pressure that can be placed on the inferior vena cava, that can actually reduce venous return, so that's why it's very important to make sure they're nursed on the left side. And in some patients, early delivery may be necessary. They may need an emergency C-section if baby's life's at risk. So there's various specialities in critical care, as treatment for the patients can differ. So sadly, small babies and children do become critically ill sometimes, and they do need specialist care because the anatomy is different to grown adults. They're not simply just small adults. And we also need to take into account any changes to our body's response mechanisms as we age. So for paediatric care, what are the differences? Well, care has to be age and developmentally appropriate, and the child's primary caregiver is included in all planning of the care, more so in adult ICU because the next of kin is directly there and they're advocating for their child. So what considerations do we need to take into account when caring for paediatrics? Well, infants in particular, they have a higher surface area to volume ratio, which leads to an increase in heat loss, and also a higher insensible fluid loss. So an insensible fluid loss it's evaporative losses from the skin and lungs, which it's hard to directly measure. And this leads to them being at an increased risk of dehydration and hypothermia. Now, infants also have reduced glycogen stores compared to adults, and they also have a higher metabolic rate. And these two combined can increase the risk of hypoglycemic events. So the fluid requirements for infants are based on their body weight. But it's important to know that the arterial blood gases and the electrolyte values are actually the same as an adult, apart from newborns, of course. So the airways are very different. In a newborn, the larynx is much smaller diameter than adults. And they've also got a short maxilla and a mandible. And they have this large tongue and a floppy epiglottis, a shorter trachea, and a more acute angle of the airway. And it requires a a specialist to come and intubate the infants when we have them in ICU. We always call the paediatric team to come and help out. So there's also some breathing differences to take into consideration when caring for infants in the critical care environment. They have a higher basal respiratory rate, and tachypnea is quite a normal response for infants. You need to be more concerned with them when they have a slow respiratory rate, as that may indicate impending cardiac arrest, not actually improvement, which we would see in adults. And they've also got poorly developed intercostal and accessory muscles. So oxygen therapy, there's a number of different options for infants when it comes to oxygen therapy. They can have nasal prongs, CPAP, BiPAP, all those that adults would have. And there's also head boxes for infants as well. So when we're assessing the airway and breathing, we need to assess the airway for patency. And are they making any noise? Are they talking? Are they crying? Is there any adventitious sounds, any wheeze, stridor or grunting? If there are any of those sounds, those children need urgent assessment and potentially early intubation. And signs of respiratory distress in an infant can be head bobbing. Head bobbing is one of the late signs when they're moving the head up and down to try and bring in more oxygen. And nasal flaring as well, and intercostal and sternal recession. Generally, when a child looks sick, so when they're really fatigued and flat, they are really sick. So a fatigued or a flat child is not a good child, and we need to get some urgent care to those. So what kind of things can lead to airway or breathing problems in infants? Well, croup, I'm sure you've heard of, is one of the most common causes, and that's acute swelling causing upper airway obstruction. It's often treated with steroids and nebulized adrenaline. And epiglottitis is inflammation of the epiglottis. That's quite a serious condition which requires urgent intubation and to be nursed upright and supported until they are intubated. And foreign body aspiration as well. Anything small enough to fit in the mouth can be aspirated. And bronchiolitis, that's common around winter time, and it's a viral condition where there's obstruction of the small airways resulting in air trapping, and that can be brought on by the common cold and bronchiolitis. And of course there's asthma as well. So when caring for a ventilated infant or child, there are some differences. So the endotracheal tube is uncuffed up until puberty, and the tube is just monitored very closely as well. And they're suctioned every 2 to 6 hours, depending on how old they are and what's wrong with them. And the suction catheter is less than 2/3 the internal diameter of the ETT. And humidification is necessary. In fact, humidification is administered on both adults and paediatrics now. So the ventilated infant or child will have an NG tube in, or an OG tube, or a gastric tube, and that's so we can perform gastric decompression because air can be trapped in the stomach, and they will need restraints to protect the airway in case they are lightly sedated and they wake up and try and pull that out. And the analgesia and sedation needs to be closely monitored. Okay, they can be on a ventilator or they can be on non-invasive ventilation, which can be BiPAP or CPAP. And they can also be on high-frequency oscillatory ventilation, which is a specialised type of ventilation which it administers very well, as it says, high-frequency respiratory rates with some vibration. And this is commonly used in patients with ARDS. So circulation-wise, we need to monitor the patient's pulses And the blood pressure, that's age related, and in paediatric areas you will often have special paediatric charts which will give you the different parameters for the different ages. And the fluids and drugs are calculated based on the weight of the child. The urine output again depends on the age of the child, but between 0.5 to 2 mils per hour. And we can use a Broselow tape to calculate the child's weight, and this is what one looks like. So circulation physiology and pathophysiology. Now, it's important to understand that children compensate for hypovolemia by vasoconstriction and tachycardia, and they can easily lose up to 30% of the blood volume before becoming hypotensive. The pulse pressure will narrow before hypertension occurs. And tachycardia is also non-specific as well, and it can occur in children who are hypovolemic, if they're in pain, if they're frightened, if they have a fever as well, if they're hypoxic, hypercapnic, or having seizures. So you've got to try and look for the cause of what's wrong and try and treat the cause. So in our older adults, adults older than 65 take up 46% of acute care beds, although they're only 12.5% of the population. So the most common causes of admissions for the older adult include cardiac arrhythmias, heart failure, stroke, fluid and electrolyte imbalances, pneumonia, and hip fractures. So the issue with the older adults in the intensive care is that they can have multiple problems and multiple comorbidities which can make the care very complex for them. They can already have arrhythmias, heart failure, stroke, fluid electrolyte imbalances, pneumonia and hip fractures. So it's important to identify falls risks, try and implement an early discharge plan and any assistance required, look at any community-based referrals and interdisciplinary teams like social care. Because often when the older adult comes into an intensive care unit, the rehab process can take a lot longer, and they will not be the same when they leave hospital. They may require a higher level of care. They may need to go into a nursing home. The assessment for the older adult is the same as with any other assessment. You perform your A to E assessment, the same structured approach. And considerations in this age group is that they are a surgical risk. So if they're going in for a hip replacement, the surgical risk is a lot higher. So they often come to ICU or HDU overnight for monitoring before we discharge them back to the ward. And they're very sensitive to changes in fluids and at a higher risk of delirium as well. And they may have some metabolic and nutritional imbalances before they come into the intensive care unit. So we're constantly chasing our tails. And they may be on a variety of medications before they come in, and they may already have existing infections as well. They're at an increased risk of developing nosocomial infections, hospital-acquired infections, and decreased immunity as well. So it's very important to make sure that our elderly patients have their pain managed effectively with the correct medication, as they may already be on a variety of medications. There may be some interactions, so we need to be careful of what we can give them. And they may be suffering from some depression as well, especially if they've been in hospital for quite a while. They may need treatment for that, or if they've had a major life-changing event, and when they discharge hospital, they're going to a nursing home, that can obviously lead to depression as well. And ultimately we need to make sure that we're meeting the nutritional needs, the physical and the social needs as well. So there's many different age-related changes and associated clinical manifestations that we need to be aware of when we're aging. There are changes to our cardiovascular system, the heart rate and rhythm. It's quite common for aged people to have atrial fibrillation and structural changes within the heart, the venous and arterial circulation, peripheral pulses, the respiratory structures, ventilation, perfusion, all changes. We can often have an increased ventilation perfusion mismatch when we age, and the lung compliance is decreased as well. So from a urinary perspective, the functioning nephrons in the kidney are actually decreased, which reduces the excretion of toxins from the kidneys. So the changes to our bodies as we age are very interesting, and there's a few tables here with some information about the different systems and what changes we can expect as we get older. So from the skin, there's spotty pigmentation in areas exposed to the sun. Moisture, the skin can be dry and scaly as we age. And fat distribution, we can have a decreased amount of fat on the extremities and an increased amount on the abdomen. And this decreased fat on the extremities can lead us to an increased risk of pressure areas, which is why it's incredibly important to perform adequate pressure area care on your patients and do impeccable skin assessments on them. So again, the list goes on from a head and neck perspective. The eyes, we're going to have decreased visual acuity. The list goes on, but these tables, I'll let you read them in your own time to have a look through, because there's a lot of information contained in here. And that goes on to the reproductive system, the urinary system, musculoskeletal system, and the neurological system as well. So, intensive care. Patients may require intensive care for any of the following reasons. So, they may be unstable from a cardiac perspective with hypotension or hypertension as well, which may need to be controlled. They may have some form of respiratory compromise, whether it's type 1 or type 2 respiratory failure, exacerbation of COPD, asthma. They may have cardiac arrhythmias. Acute renal failure is very common in the elderly, and that's due to the reduced nephrons. Multiple organ failure. So it's very important that we carry out intensive invasive monitoring on these patients. They may be coming to us post-surgery just for that 24 hours of intensive invasive monitoring if they have a lot of comorbidities. So thank you for listening to this lecture. Here are your list of references. Thank you.